Assalamu alaikum. Welcome to today's cataract surgery insight into achieving a double Rhexis. I'm Dr. Abdur Rahman Mohammad going to perform this surgery. Anterior capsule is stained with tryphin blue. Main port is being created with a 2.4 mm steel curved dome. A bipanel incision has been made. Now I'm incising the anterior capsule with the help of a bend system. In doing so, there is spontaneous decompression of the intercapsular pressure. Inject OVD to remove the liquefied cortex and to pressurize the anterior chamber, thereby flattening the anterior capsule and causing less tension on the anterior capsule so it will not radialize. Now, with the help of a bend system through the side port, perform the Rhexis. In doing so, less OVD is leaking through the side port. If I have used the main port, then lot of OVD would have prolapsed out and the Rhexis might have run out and the AC would have shallowed. Now after performing the primary Rhexis, I am removing the liquefied cortex with the help of a bimanual IA handpiece. Now with the help of a micro Rhexis scissor, I am cutting the Rhexis margin. A tangential cut has given in the Rhexis margin. Then with the help of a Rhexis forceps, I am guiding the cut flap in a circular manner, thereby creating a large continuous curvilinear capsule Rhexis of 5 mm. Whenever the anterior chamber shallows, repeat injection of OVD and pressurize the anterior chamber. Thereby, you will not face any difficulty in making the Rhexis. Now, Alhamdulillah, now I have made a 5 mm continuous curvilinear capsule Rhexis. Now I'll be sculpting out a central plate in the nucleus. Thereby, I will expose the endonucleus, which will help me in chopping the nucleus. I like to perform vertical chop. I chopped a piece but it failed to separate at the posterior plate. Again, I'm going deeper and deeper but the posterior plate refused to chop. So I'm not worried. I'm chopping and seeing if any piece separates. I think this piece separated. Now all the pieces are attached to the posterior plate. Now slowly I'm not giving up. Yes, I have chopped a piece. Now I'm pulling it out and I'm emulsifying it at the pupillary plane. I'm sub-chopping it with the help of the Sinski and I have emulsified that chopped piece. Now another piece has been separated. I'm emulsifying it. Still, these pieces are attached to the posterior plate. Again, I'm performing another chop. Yes, I was successful in separating this piece. Now I'm emulsifying it. Now I decided to flip the nucleus to reach the posterior plate. Now I'll slowly cut at the posterior plate and separate these pieces which are attached to the posterior plate. I think I can make 3 pieces. Yes, there is one piece. Now this 2 piece also I'm emulsifying the posterior plate. Yes, I have made 2 pieces. Now slowly I'll emulsify them carefully because the bag is empty, and epinucleus mode I'm removing this last piece. In epinucleus mode I have a reduced energy aspiration flow rate vacuum, thereby I will less likely to catch the posterior capsule during vacuum-emulsification. Now after removal of the nucleus, I'll be performing cortical removal with the bimanual IA handpiece. Now enlarge the main port to 2.8 mm with the help of a steel keratome. 2.8 mm main port will help in easy placement of the nozzle of the cartridge in the main port, thereby ease of IOL implantation in the posterior capsular bag. Thank you, my dear friends. Hope this cataract surgery insight was helpful in developing your surgical skills.